thank Professor Sudha Sheshan, the Vice Chancellor, for giving me this opportunity to share our experiences with the changing management of lung cancer in the United Kingdom. Lung cancer still continues to be the most common cause of death in the UK as far as cancers are concerned. It has overtaken breast, and as you can see, there is a drop among men in the incidence of lung cancer purely because of a reduction in smoking. However, if we look at the population of women, it seems to be going up. And the trend really is secondary to smoking in the Western world. A lot of awareness programs have been put in place to try and mitigate this effect. And I'm pleased to say that in the most recent consensus in the UK from NICE, it shows that the trend continues to drop both among men and women. Now, in the United Kingdom and in Scotland, we have national guidelines put into place. And the National Institute of Clinical Excellence, which is a English organization, the Scottish Intercollegiate Guidelines Network, which is based in Edinburgh, and the British Thoracic Society work in collaboration to try and see how we can treat patients with lung cancer in every stage. In 2019, the NICE guidelines suggested that all of these patients who have a positive intrathoracic lymph node, then a systematic approach using any of these modalities of CT scan, positron PET scans, or ultrasounds with either endobronchial ultrasound or transbronchial nodal aspiration, or with endoscopic ultrasound with FNA, if the nodal status would affect the treatment plan. In other words, in simple words, we must sample the nodes to stage the cancer. And it also stated that we must consider surgical mediastinal staging for people with a negative EBUS or EUS if clinical suspicion of nodal malignancy is high. And that, if you like, is secondary to the size of the node. If it's greater than 1 centimeter in diameter, then it normally should be biopsied to stage the cancer. So this, if you like, was NICE guidelines in 2019. Now, they also published a document for diagnosis and management. And there were very clear guidelines with stage 1 and stage 2, but stage 3, to get them more into the surgical arm, they said that with operable stage 3A, with nodal disease, patients should be considered for multimodality treatment. That is with chemotherapy, radiotherapy, and surgery. Before or after is again a discussion with the multidisciplinary teams, which I will discuss in my lecture. Now, the new modality which we are seeing more and more in the West and in Japan is the ground glass opacities. These GGOs or GGN nodules are focal areas of increased lung attenuation on the chest CT, through which normal parenchymal structures like the airways and vessels can be visualized. Now, the pathology is predominantly called lepidic or butterfly component. These used to be called with a different name in the past, called the bronchoalveolar carcinoma. But the pathologists felt that this is now old hat, and we really need to look at it as an adenocarcinoma. The definition of a GGO is when you do not have any consolidation of the lung tissue and there are no solid parts. The current World Health Organization classification of these ground glass opacities are pre-invasive, minimally invasive, and invasive. And all these have now been put together as adenoma or adenocarcinomas. So the pre-invasive lesions are atypical adenomatous hyperplasia, adenocarcinoma in situ, when it's less than 3 centimeters. They are non-mucinous, they are mucinous, or the mixed variety. Then you have the minimally invasive adenocarcinoma, which is again divided into non-mucinous, mucinous, and mixed. And you have the invasive variant. Now, extensive sampling of these GGOs is needed to exclude invasion because that changes the treatment plan. I just want to go through this eighth T classification because it has significant impact on survival. So this is not new. You have from primary tumor TX, where it cannot be assessed or the tumor is proven by presence of malignant cells. T0 is where there's no evidence of primary tumor. T1S is carcinoma in situ, and so on. All of these things keep changing because it's dynamic, because it's the eighth edition. And the reason for that is to look at survival and try and classify these tumors to make the patient's journey with the cancer treatment as optimal as possible. Now, what happened in the United Kingdom? And this is the bit that I wish to share with you today. The overall survival for lung cancer in the UK was pretty dismal. It was about 5%, which is not stage specific. In other words, from stage 1 to stage 4, the overall survival was around 5%. The thoracic community of thoracic physicians, surgeons, pathologists, oncologists looked at this some 15 years ago and felt that we were far behind Europe and we were also far behind the United States, where the resection rates were anywhere between 10 to 25%. So the government in the UK, the Health Department of Health, decided that what we needed to do was to establish cancer networks. And these cancer networks are local, regional, and the national grid was really the National Institute of Clinical Effectiveness. So what does the local cancer network do? It collects data about every single lung cancer patient who is diagnosed in the UK. The multidisciplinary teams meet at least once a week. It is chaired by rotation, either a surgeon, a physician, an oncologist, or a radiologist chairs the multidisciplinary team. And the team consists of chest physicians, radiologists, pathologists, oncologists, the lung cancer nurses, and the thoracic surgeons. This is a great learning opportunity. Once a week, you sit down for an hour or hour and a half with all of the patients who have been diagnosed with lung cancer in that unit or hospital. What does that actually do? It gives you a pathway for treatment for every patient, albeit stage 1 or stage 4. It'll be very interesting to see that patients who come for palliative care with the kind of treatments that are available now, their quality of life can be extended, and the extension can be anywhere between 6 months to 12 months with a lot of new chemotherapeutic agents, with immunotherapy, which is coming on board, patients being involved in trials by the oncologists. Fascinating. If they have pleural effusions, the pleural effusions can be drained using a minimal access approach by the thoracic surgeon. We can send them home with stoma bags where they can empty the effusion and after a period of time, they can be insufflated with talc. So there are a variety of treatments for these patients which keep evolving. So the big three, secondary to smoking, the noxious gases in the urban areas in the Western world, causes increased hospitalization, and what we need to do is try and see how we can reduce the mortality. We need some screening tools to prevent this to progress. And we also need to have some early diagnosis with low-dose CT scans, which have been proven by the LCAP trial in New York. We need to treat the smokers. We need to make them come off the habit, and we also need to make sure that ex-smokers are kept without going back to smoking. We, as clinicians, need to influence the guidelines which the government wishes to put forward. And we are very, very important in influencing these guidelines. And the big three concept is a holistic approach of the major smoking-induced diseases. Smokers give rise to diseases of the lungs with lung cancer and chronic obstructive pulmonary disease. It also goes on to cardiovascular diseases. So screening of smokers for susceptibility of these chronic diseases is a must. The CT screening for smokers for early diagnosis is very helpful because it then goes on to helping patients with a cure in stage 1 lung cancer. And there are new treatments for smokers and ex-smokers which need to be explored. And this ultimately influences the guidelines for care of patients with COPD, lung cancer, and cardiovascular diseases. So for lung cancer, what are the treatment options which are available to us at the present time? Can we cure it? Probably, because now we see that the stage-specific treatment for lung cancer can lead to longer survival periods, especially if you have a T1 lung cancer. So cure can be affected by surgery, by radiotherapy, and by adjuvant chemotherapy, or a combination of all three of these modalities. Palliation for patients who have advanced lung cancer can be carried out by simple surgery of utilizing video-assisted thoracic surgery for drainage of malignant effusions associated with chemotherapy, excuse me, radiotherapy for patients with stage 4 lung cancer to debulk the tumors, especially in the trachea, photodynamic therapy to treat the spread along the trachea, utilization of lasers to help patients who have obstructions, and placement of stents. So there's a huge variety of treatment modalities available for all of these patients. And as far as surgery is concerned, the role is present at every stage of management, stage 1 to stage 4, as I've alluded to in my talk. The surgeons help in diagnosis by utilizing minimal access and by either flexible or rigid bronchoscopies for biopsies. We help in staging by doing mediastinoscopies to biopsy the lymph nodes to stage them and to get the histology. We stage by using video-assisted thoracic surgery to get pleural biopsies to look at the inside of the chest. And then we are involved in curative surgery with lobectomies or pneumonectomies, and in stage 4 for palliation of symptoms. Now, are these patients who come to you operable? And if they are, can the tumor be resected? These are two important areas which need to be absolutely clear before we embark on a treatment plan for the patient. Now, what does operability mean? Is the patient fit for surgery? If we take out either a portion of the lung or the whole of the lung, will this patient be able to go home on the fifth postoperative day? Because in thoracic surgery, you always remove something and make the patient better. In cardiac surgery, you always fix something either by grafting a obstructed vessel or by replacing a valve which is either incompetent or or is stenosed. So thoracic surgery is slightly tricky. And the resectability. Can this tumor be completely excised? Have we taken all of the tumor out? Have we taken all of the nodes out? Because doing an incomplete operation is doing a disservice to the patient. So what do I, as a surgeon, need to know? I need to know the extent of the disease. Is this disease local? Is this disease regional within the chest? Or is this disease distant, involving the whole of the body? And the next thing I need to know is histology. Is this a histological situation where I can operate? Or is this a histological situation where it's an oncological treatment? For instance, if it is a small cell carcinoma, the chances are that you will not be in a position to offer a surgical treatment plan. On the other hand, if it is a very small cell cancer which has been incidentally picked up with extensive investigations showing no spread, then maybe, but this is just a 3 to 5% chance in small cell lung cancer. But if it is a non-small cell lung cancer, then the chances of staging it, offering surgical management plans with or without associated chemo or radiotherapy is what I need to know. So how do I go about coming to a conclusion that this is the patient who I can offer surgical treatment? I need the investigations, a chest X-ray, a CT scan, a PET scan, an ultrasound scan if necessary, or an MRI. An MRI is a modality which is useful in certain situations with chest wall involvement. A bronchoscopy to ascertain the tumor, location of the tumor, and also to get a biopsy. And then a mediastinoscopy beside the bronchus and the trachea to do mediastinal lymph node dissections to send it off for histology in order to help with staging of the lung cancer. So the basic investigation which a general practitioner does in the UK is a chest X-ray. Now, a chest X-ray is just a photograph. We don't know where exactly the shadow lies. Is this in the anterior aspect of the chest in the mediastinum? Is it in the posterior mediastinum? You can see that there's some tracheal shift. There aren't any pleural effusions. So this, if you like, is just the starting point of the investigations. Now, this is a CT scan, both with the lung windows and the mediastinal windows. And you can see that the lung windows shows you a consolidation in the lower lobe of lung. But then the mediastinal windows gives you a little more information on the status of the nodes. And you can see these nodes over here, which are enlarged in the peritracheal region. So this is the second investigation of use for the clinician. And then we go on to the PET scan. This positron emission tomography gives you an idea of the metabolic activity of the tumor and of the lymph nodes. Now, if the PET scan shows that the FDG uptake, which is really a fluorodeoxyglucose, which is an analog of glucose, which is injected intravenously to show the uptake, which means that the metabolic activity of that area is high, and therefore cells are replicating, and the chances are that this is malignant. But it gives you a measure of what is going on all over the body, because some patients with even with stage 1 lung cancers can have deposits in the brain. So you may have cerebral metastases, and to subject that patient to a surgical procedure is unethical. Now, what you see here is the collection of the FDG in the bladder, which is normal. But what you see here is abnormal, because that is where the stage 7 lymph nodes at the bifurcation of the trachea lies. So we talked about some additional imaging, the MRI. MRI is very helpful in Pancoast tumors which are superior sulcus up in the upper lobe, which are abutting against the vessels and the nerves at the thoracic inlet. And you see that the CT sensitivity with the vertebral and upper brachial plexus is only 63%, whereas with the MRI, with magnetic resonance imaging, it goes up to 94%. So the MRIs are useful in superior sulcus tumors and also in tumors which are adherent to the chest wall. So there we go. We've done the bronchoscopy, we've got a fine needle aspiration, we've done the mediastinoscopy and mediastinotomy, a VATS biopsy if necessary, either an open biopsy or a lymph node biopsy are all necessary for the diagnosis. Now, the next most important thing is to exclude N2 disease. Because if you have N2 disease, then the debate in the multidisciplinary team meetings is whether this patient should be subjected to a trial, whether the patient should receive neoadjuvant chemotherapy, or the patient should receive neoadjuvant chemotherapy and radiotherapy and assess after the treatment to see whether there has been any reduction in size, whether the chemotherapeutic agents have acted, and if they have, and if radiotherapy has helped, is this patient now fit for surgery to remove the tumor in its entirety, or is this patient not fit? Now, there is an argument saying that if there is a reduction in size of greater than 50% of the tumor bulk, then obviously this patient has had a very good result with the treatment modalities which have been given to the patient. However, if you look at the surgical specimens which have been removed, there are still some viable cells which are seen in the tumor bed which has been removed. And therefore, the feeling is that this may recur. And if the patient is fit for surgery, then removal of the whole of the tumor is probably the best way forward for that patient. But that, if you like, is in consultation with the multidisciplinary team and an informed consent with the patient. So this, if you like, is a cartoon of the cervical mediastinoscopy. We have got the lymph node chart. And when we do the operative procedure, we make sure that we send specimens from various zones. These are now called zones. The lymph node sampling should be at least from 3 zones for the pathologist to look at. And if you can, the best thing to do is to take rather large chunks of the lymph nodes to make sure that the pathologists have multiple cuts to confirm the diagnosis. Now, this is the Chamberlain procedure, the left anterior mediastinotomy, which looks at nodes which are around station 5 and station 6, which is the periaortic and the nodes which are surrounding the pulmonary artery. Video-assisted thoracic surgery gives you a holistic look inside the chest to make sure that there are no pleural deposits. Sometimes even CT scans can and PET scans can skip very small pleural nodules, and therefore doing an VATS procedure to have a look in is not a bad idea if it's available in your center. The endobronchial ultrasound and the endoscopy, the esophageal ultrasound are mainly done by physicians in the United Kingdom, but surgeons are also embarking on it to make sure that they do not leave any stone unturned. Now, these are just guidelines which are put up on the radical management of patients with lung cancer. It states very clearly that if it's T1 to T2 with N0, then surgery is the best approach to treatment. But if there's N2 disease, then clearly this needs to be classified either as a single station N2 or multi-station M2. If it's multi-station N2, then we've got to see whether it's bulky N2. And if it's bulky N2, then clearly the 5-year survival drops with surgery. And therefore, these patients should be treated with the other modalities which are available. Now, if we look at this paper from Alban, radiotherapy plus chemotherapy with or without surgical resection for stage 3 non-small cell lung cancer, which is a phased randomized controlled trial, shows very clearly that if the nodes are not involved, you have a 5-year survival of 41%. If the nodes are involved from N1 to N3, then the 5-year survival drops quite significantly. But if these patients are not subjected to surgery at all, then there's an 8% survival. So if you like, with this sort of evidence, which has been around for a while, the trials which are being done, as I suggested, for this group of N2 patients is to see whether you can downstage them by chemoradiotherapy, repeat the mediastinoscopy, see if the nodes are involved or not. If they're not involved, go on to surgery. Again, these are meta-analysis of induction treatment in patients with N2 disease. Now, now that I know what I need to know as far as the investigations are concerned, and I have a management plan, I need to know whether the patient is fit for surgery. What is his exercise tolerance? What is his respiratory function? What about his cardiac function? His past medical history? Does he have any other problems? And his attitude. Does he really want to have what is probably a fairly major surgical procedure? So, if we look at this CT scan, you see that there is a small nodule in the periphery of the left lobe of lung, the left lower lobe, and that is where it is. Now, if we look at the PET scan, it lights up, and you know that it's metabolically active. So, what do we need to do? We need to make sure that his cardiac evaluation is done properly. He has an ECG. It shows a right bundle branch block. This guy is a 70-year-old gentleman, and his cardiac ultrasound is normal. His left ventricular function is normal. And then he's put onto a cycloergometer. He has no induced coronary ischemia, and his VO2 max is much higher than the normal of 10 to 12 ml per minute per kilogram body weight. So his VO2 max is fine. His lung function shows that his vital capacity is 107% predicted, and his forced expiratory volume in 1 second is 57%, and his carbon monoxide transfer is 49%, which means that he will stand a lobectomy without a problem. So this guy has a mediastinoscopy, and the lymph node in station 4 on the left side shows that it is positive for malignancy. But his station 7 at the bifurcation of the trachea, his station 4 on the right paratracheal region, is station 2 and L are negative. So this is a guy with a single station N2 disease. So he has intranodal metastases. He has his induction chemotherapy. He has 3 cycles of carboplatin and pemetrexed, and he is discussed in an MDT with all everybody present, and is considered for limited resection. So that, if you like, is the pathway that we follow in the UK at the present time. Now, what are the contraindications for surgery? Metastatic disease present in 60% of time at the time of presentation in the UK. And some of these are into unremovable structures like the superior vena cava, the esophagus, the vertebrae, mediastinum, and the great vessels, and malignant pleural effusion. Having said that, if these patients are very carefully staged, and if they are T4, which means that they have extended to a mediastinal structure, but the nodal status is 0, which means there's no involvement of tumor in the nodes, then there is a view that patients can undergo surgery with removal of a portion of the SVC and reconstruction, in the spinal surgeons helping to remove the vertebral component and take out the tumor. In my own unit, we tend to do superior sulcus tumors with the open method of reconstructing the subclavian artery, the posterior approach where we can sacrifice the T1 trunk. So we have the expertise in our unit to do the Dartwell procedure, which is fairly extensive, but it's quite rare. So, what is the risk that we quote for patients in the UK regarding various operative procedures in the lung? As far as wedge resection is concerned, it's 1 to 5%. Lobectomy is almost 2 to 3% now. Bilobectomy is 3% mortality. Pneumonectomy is still a bit high, especially on the right side, with 5 to 10%. And chest wall resection is secondary to what each unit does. It depends on the extent of the chest wall resection, whether it's just resection of 1 or 2 ribs, or whether it's a resection of 5 to 6 ribs. Lung cancer surgery does have its quota of morbidity, postoperative bleeding, chest infections, wound infections, pleural infections. Some of these patients go into acute respiratory distress syndromes, and BPF, especially on the right side, is still prevalent, but not as much as it used to be in the past. And post-recovery symptoms is very important because the chest physiotherapists come into their own at this stage where patients, especially in the UK, patients who are 70 and above have some breathlessness, some COPD, so they need a lot of help with chest physiotherapy, psychological morbidity, because a lot of these patients in my part of the world live on their own. Fatigue and decrease in appetite has to be addressed with supplemental drinks and making sure that the occupational therapists and the girls in the department take care of their diet. So come back to the classification of lung cancer, which is very important for patients to be treated appropriately according to the stage for the survival. Is this just a slide which I put up? If you notice, the 6th edition was based on data from about 5,319 patients with non-small cell lung cancer. And it was revised in 1997. It was published in 2002. It was validated by Naruki in Japan in 2004. However, this is evolving. It's dynamic. As more and more research is formed in the world literature, you keep on increasing the TNM classification. That it's in the beginning of the lecture, I showed you that it was in stage 8. So the improvement in treatment for lung cancer is progressing by the decade. Now you see, the ISLC lung cancer staging project was launched in 1996. And from 5,319 patients, now it's gone up to 67,000 patients of non-small cell and 13,000. So there is a world consensus that we need to look at this carefully to improve patient treatment plans. Now, finally, to look at the palliative surgical treatment. Um, these are mainly endobronchial treatments and for the chest wall. With endobronchial treatments, you use a rigid bronchoscope to debulk, you place stents, you use laser treatment to debulk and to remove the tumors blocking the bronchus and the trachea. And we also have a small experience with photodynamic therapy. So ultimately, the 5-year survival for these tumors, if it T1N0, which means they are small, they're less than 3 centimeters, the survival is anywhere between 60% upwards. For the T2 tumors, it's around about 38%. And you will see that when the nodal involvement happens, the survival rates start dropping. So what happened to us? So when we started all of these cancer networks and we started the multidisciplinary team meetings, the UK resection rate doubled from 5% or 8%, it went up to 10% resection rates. And what happened in my center, the Pan Birmingham network, our resection rate went up to 19.6%, which is, pretty laudable because this really was because of a coordinated approach from a variety of clinicians who contributed to this terrible disease. Now, I have a couple of videos so that I don't know whether I'll be able to put them on, but if I can't, then I'll take some questions. Is that okay?
Yes, yes, sir. Please try if you can have those videos, and then we can go for a discussion.
I'll see if I can exit. Trying to. Can you see this on the screen?
Not seen.
Not seen. Okay. Can you see that now?
Yes, yes, we can, we can.
Okay. This is just a video of a patient who underwent a video-assisted lobectomy, lower lobectomy. This is for Babatosh and the rest of the crew. That it's minimal access. We do this with a thoracoscope. Just want to show you a edited 10-minute version of how a large tumor in the lower lobe can be removed through a minimal access approach. Babatosh, this is a 3-port technique. which we perform, and we tend to use most instruments which are available. We don't use many fancy instruments in Birmingham because, we like to cut costs. And you see that there is a 3 centimeter tumor in the lower lobe, which I personally like to palpate with my finger. I put in my finger through the access port and make sure that I can feel the tumor. And I use just a Robert's forceps with a peanut to ascertain. And then I use 2 peanut forceps to create the fissure. I don't use the stapling device until it's absolutely necessary. And you can see the pulmonary trunk with the branches, and you also see the lymph nodes on that pulmonary vessel. And once, just by gentle teasing, you can clear the tissue around the pulmonary sheath. And what I want to demonstrate in this video, which I use for teaching, is how to cut into the pulmonary sheath without um, injuring the pulmonary vessel. I think, first open surgery and then with video assisted technique, you tease it out and then enter into the pulmonary vessel sheath, not the pulmonary vessel. And then you can take these lymph nodes out at the same time. You see, just by gentle teasing, you open out the pulmonary sheath. And once you have control, after, having a little lateral and proximal control of the vessel, I normally put a sling around before I push the staple behind the vessel. That, if you like, is the pulmonary trunk. And you can see the vessels to the lobes going, excuse me, going down. I use the stapler to facilitate access, really. And as you can see, this is again a Robert's forceps, which I place across below the vessel. Sometimes a right angle is also useful. And then I place a sling. And that's a vascular stapler, which we use to staple the blood vessels. I go for the vessel first, and sometimes if the fissure is incomplete, I don't bother about creating the fissure, because once you get the vessels, you then can create the fissure at the end, and I'll show you how I do that in this particular video. Sorry about my throat. I've just recovered from a little mild bout of flu. That, if you like, is a technique to get across the fissure and come to what is the bronchus in the back. Because the vessel, the inferior pulmonary vein has still not been dissected free. So I put a sling across to delineate the whole of the fissure. You can see the azygos at the back. They introduced the staple for the lung, which is a thick stapler, 4.8 millimeter leg length to the staple. And now that the fissure has been completed, now you can see that everything falls right in front of you, like a book, open book. So you can take the vessels going down to the low lobe. You can either take them individually or you can take them, if you wish and you have the guts, you can take both vessels together. But I don't have the guts. Therefore, I'm a bit more conservative and make sure that you take that individually. These stapling devices have really revolutionized the way surgery is being performed nowadays. Now, that, if you like, is the inferior pulmonary vein. Once you take these structures down, you can see how it all just falls in place. And for anybody who wish to start doing minimal access surgery, please do. We've been having a lot of discussion in the college about introducing laparoscopic surgery in rural areas, in remote areas. To me, I think, people may have this feeling that, oh my God, there's so much of cost involved in these things. But if you can tailor it with low resource areas, if you can reuse some instruments, the patients who are even in rural areas can get back to work quicker. The amount that is the lower lobe bronchus, which I'm stapling right now. You see, the rural population can benefit even by simple treatment for pneumothorax, for pleural effusions, for diagnosing tuberculous pleural effusions. It'll help, instead of doing big operations with, chances of morbidity. If you have a big thoracic scar, then patients will be frightened, especially in the areas where getting, specialist treatment is difficult. So I use an endo bag, which I place through the port side and deposit the lobe into the endo bag so that there isn't any spillage at the incision site to prevent any chance of a metastasis at a later date. So the whole of the lobe is placed inside the bag. Excuse me. And I just place one drain in the chest. We don't really need a drain for air and for effluent like blood or any fluid. The amount of drainage from these video-assisted techniques are very small, and they're up the following day. And normally, these patients leave the hospital on the third postoperative day. So that, if you like, is my video, and I'm open for questions. Thank you very much.
Thank you, Professor Rajesh, for that excellent scholarly presentation. And we could sense the glint of your experience when you said cardiac surgery and thoracic surgery are different. Cardiac surgery, you fix something and help the patient. Thoracic surgery, you remove something and help the patient. I think that capsules the entire gamut of cardiac and thoracic surgical procedures. Let me now request Dr. Babatosh Biswas, who's here with us, former Vice Chancellor of the West Bengal University of Health Sciences and a cardiothoracic surgeon of repute, to give his remarks. Dr. Biswas, please.
Yes, ma'am. Let me congratulate Shudha for your excellent arrangement, organize such an webinar. And we are all grateful to you and my great friend Rajesh. Yes, I am delighted to see his very simplified video. It looks very simple, but the way he has made it simple, that is what everybody has to learn. And it was a excellent and very, very clean surgery. Looking such a video for youngsters, it becomes very, very helpful and they get lot of confidence. And what I saw in this video, that is superb and everybody should learn it. And Rajesh, I would like you to ask one simple question, which I had a recent experience. Such a clean growth in a patient of 69 having no other comorbid, detected incidentally and present with some chest pain, and that showed multiple local erosion in the spine. No secondary anywhere, but not single, multiple osteolytic lesion, and PET CT showed those are active. So should we go for local resection or it should be neoadjuvant radio followed by local resection?
Babatosh, what was the histology?
Adenocarcinoma, adeno.
Oh, so multiple in one lobe, or is it in two, three lobes and in
No,
both
no,
sides?
it is a single growth in lower lobe, but
Okay.
multiple lesion in contiguous adjacent spine, bony lesion, multiple. He presented with bone pain, nothing
Oh, I
else
see.
anywhere.
I see. Babatosh, if it is spine and if it's bone, then the chances are that this is a hematogenous spread. It is not a
Yeah.
lymphomatous spread. So I agree that surgical intervention is probably not the right thing to do. I think chemoradiotherapy, and if it works, if chemoradiotherapy works and his bone pain gets better, then you can look at what you can do for the tumor. But I don't think that in my practice, I would subject that patient for any surgical intervention.
What is my confusion here?
Mm.
Presented with pain, and this growth was sitting on the spine, bone was eaten up, absolutely contiguous with the growth.
Mm.
So, could it be that it is local inflammation of the bone? And in that case, should it be any different mode of principle of surgery?
See, for that, what you really need is a PET and a bone scan. If there is any evidence of more than one vertebrae, then I think you'll need the spinal surgeon to see if he can remove, but make sure that they can fix the spine.
Hmm.
I mean, in Birmingham, we tend to do patients who have these tumors which abut the spine, but if there are multiple lesions, then highly unlikely that we will proceed to surgery.
But ordinarily, all these patients should go for chemoradiation followed by surgery.
Yeah.
That is,
Yeah,
that should be the
that if you
standard
like
also.
is the guideline here, that if patients do present with N2, with T4, then they are discussed and they're sent primarily for chemoradiotherapy, depending on the oncologists, whether they are medical oncologists or radiation oncologists. They tend to do the discussion among themselves and they either put them through just radiotherapy, depending on the biology of the tumor, or they give modality treatment with both chemoradiotherapy. If things settle, if the patient has major improvements and the biopsy after you do this modality, because in the UK, it's National Health Service, so patients are put into trials for these reasons. If the biopsy is negative, then the discussion is with the patient to see whether they want the tumor removed. Some of them do want, even if there's a residual scar tumor, some of them wish to have it removed. And if they wish to have that removed, then on a case-by-case basis, we tend to do it. He's young.
Can I
59
ask
is still
one
young.
more question, Sudha? Sudha, Madam Sudha, can I ask one more question?
Yes, please go ahead. Please go
Yes.
ahead, sir.
Uh, because I get tempted to ask anything from Rajesh whenever I come across. I have a lot of queries to him.
And we are tempted to listen to both of you.
Yeah. Recently, I had one case, absolutely single small growth in lower lobe with single N2 node that came to be PET positive. What should be right policy in this question? Single growth and one PET positive N2 node.
That is not a problem at all, Babatosh. What I would do if he was in my clinic, I would counsel him to have his lobectomy. I would do 3-zone lymph node clearance, because with single N2 disease, single station N2 disease, surgery with nodal sampling and 3-zone resection is the treatment of choice. Because
Is it beneficial? Sorry, is it beneficial to put them to neoadjuvant chemo than to surgery? Because I had a lot of interaction with the oncologists regarding head-to-head comparison, and the oncologist involved, they insisted to go for neoadjuvant followed by surgery.
If
So what
it
is
is
your feeling?
biopsy proven, and if you want to give what is the histology again?
Again, it was adenocarcinoma.
Okay. I would certainly give the patient, carboplatin, pemetrexed 3 cycles, and reassess by doing a mediastinoscopy, get a histology, not just that node, but other station 7, both right and left, 2 and 4. And if it is work, just go for surgery, remove the lobe.
Probably these are the cases where nodal clearance should be done as a diagnostic process.
Absolutely, because I think if you take out as many nodes as possible, then the chances of complete staging after surgery is good. And also it helps in the 5-year survival of these patients. And you build a repository as well, Babatosh. The more you do and the more you record, the more it helps in decision making in future for the next bunch of patients.
And these are the classical cases for mediastinoscopy. In the era of other diagnostic imaging, this is the classical indication of mediastinoscopy, isn't it?
Absolutely. Completely agree.
Yes, sir. This is why I wanted to hear not only myself or younger and older surgeons, because nowadays mediastinoscopy has become a forgotten art. So people of huge experience like you, hearing from your mouth the role of mediastinoscopy in such cases gives everybody enough confidence that yes, it is the investigation which must be practiced in a couple of indications. So
thank you.
Thank you, Rajesh. Excellent information. And I'm feeling really absolutely happy and enlightened. And my all regards to you and Shubh Navaratri to all everybody.
Thank you.
Sudha,
Thank you, Professor Biswas. And may I now request Professor Bashi for his remarks?
First of all, I must thank our Vice Chair, Dr. Sudha, for inviting me and organizing a nice, excellent program. And thank Dr. Rajesh for giving an excellent lecture. In fact, in my initial 7-8 years, I was doing only thoracic surgery. Now, of course, still I do few lung surgery, I never say no to a lung operation. So it was very nice to. In fact, this month I had 2 lung resections with 2 patients. Both of them had a colonic carcinoma treated 8 years ago.
Oh,
8 years ago, yeah.
metastasis.
Yeah, so both, one had a right lower lobectomy, another a left lower lobectomy. Of course, there was no other secondaries.
Brilliant.
So, I mean, is it possible? Because I have not seen a patient coming after such a long time after a colonic carcinoma coming with the secondaries. What is your take on that?
See, Bashi, you know, a cancer is a cancer, you know, in our parlance, really. With the a colonic cancer being a adenocarcinoma, 8 years, 10 years, it may be a second primary, we don't know. But on the other hand, if it's an isolated lesion, the best modality is to do an excision biopsy, you know, because that is a malignancy until proven otherwise. Here, if we can spare parenchyma, lung parenchyma, we tend to do segmental resections. But if the lesion is large, then what you have done is the right thing of doing a lobectomy. And what I would do is to also take some, I mean, I'm sure you've done that, also take some lymph nodes out just for survival data. You know, if the lymph nodes are positive, then the 5-year survival drops down to about 28-30%, even in metastases, because we have a very large experience with colonic and hepatic cancers in Birmingham with metastasectomies. And I think any tumor which comes after 5 years should be regarded as a second primary. But if the pathologists say that this is an adenocarcinoma with a predominance of colonic, mucin producing carcinoma, then we should consider that as a secondary deposit. But in any case, the treatment is the same.
Yeah, both were adenocarcinoma, and I have done a complete clearance of the lymph node. Luckily, and they are big tumors also, actually about 6-7 centimeter in size.
Wow.
Surprisingly, all the lymph nodes are negative. Both cases it was negative. Actually, one patient is in the ward just now.
Right.
Yeah, another thing I mean, in this context, I also want to, see, the thing is, unfortunately, we don't have any statistics from our country.
Sure.
To have a database, and all, I think you should be able to help us in where ISCTs. Actually, we are trying to have a database now for this all the thoracic, cardiac, and everything. So I think it's important that we should have some data from our country, to throw some more light on the pathophysiology, and because incidence, the disease pattern, recurrence rate, presentation, all, as you know, is all totally different here.
Yeah.
How we can go about it, I think you should be able to give some inputs into that.
Definitely, Bashi. See, we are going to meet next October for the Royal College meeting. We are getting Tyrone David from Canada to come for the meeting, and Babadosh, we are also getting Peter Licht from Denmark to come for the meeting in Chennai. It'll be a great forum to talk about these things. And Bashi, I don't know whether I've got the dates for the Jaipur meeting. But if we can always discuss how the college can help with, setting up a database, interaction between our two nations, because I think it's very important, because we will learn from what is happening in India as well. It's not just India you're learning from the UK and the US. UK and the US is for their population. Well, how we can help our own patients is very important, no? 59-year-old patient, he's young. We need to make sure that there is a, pathway, a treatment protocol for these people, because we have some brilliant oncologists. We have some brilliant, diagnostic radiologists in our country, and we really should be coordinating all this.
And one of the things which on the lighter side, what has happened now of COVID is, whatever said and done, the CT scan centers are there all over the country. So much of scan centers have come. See, like an X-ray, CT is being done all over the country. So the pickup rate, because see, in 1987, I was in Royal Adelaide Hospital. Those days, I used to get amazed. But even with 1 centimeter lesion, patients are referred for lobectomy. I have done lung resection there, which I've never seen in Vellore when I was there. Clinically, 50%, like the 50% story, 50% inoperable clinically, 50% of them operable clinically, 50% inoperable on the table. Of that, 50% will not survive more than 5 years. That was the story when we studied. So I used to be amazed about 30 years ago, the pickup rates with the CT scan. So with the improvement in this development, we should be able to get a lot of data from this. Even the scan centers itself, they connect together itself. That will be a very big thing. We should seriously think about, so that it can be picked up early, so that more people can be, given the benefit. And a lot of surgeons are getting trained simultaneously.
Absolutely,
Yeah, these are a few things I would need your, because being a person who has been involved closely with our association and everything, you will be, you should be able to help.
I'll be delighted to help. I'll be delighted to help.
Yeah. Thank you, sir. And we have Dr. Raghunandanan with us. Raghu, sir.
Yes, madam.
Cancer is something which is very, very compounded, especially if you look into the pathomechanics of lung cancer. It's not only, molecular changes that happen. There are morphological changes in the cell mass, molecular changes, and more than that, genetic alterations. Studies indicate that the imbalance between the oncogenes and the suppressor genes play a key role in lung carcinogenesis. So Raghu, can you throw some light on that, and what had been your experience with regard to what Professor Rajesh said? There is an increase in the incidence of lung cancers amongst women. In the Western world, he said the reason could be smoking. But then what had been the Eastern world's experience?
Thank you, madam. To be very honest, actually, I'm a basically general physician dealing with more of critical care and toxicology services. But in fact, I wanted to put basic question to sir, because still, if my basic knowledge goes.
Question him. He is there in the hall, very much in the hall. You could still ask him some questions.
Yeah. So the question is, for example, in our state government now we are going for a screening, non-communicable disease screening program, and at present our government is focusing on CSS and oral cancers. But as madam said rightly, the incidence of lung also is on the rise. So can you suggest a cost-effective community-based screening program, because you are mentioning about the PET scan and MRI? Can, as a basic doctor, I want to know whether screening, suppose if I'm suspecting some lung malignancy, can PET scan be a tool to rule out a cancer of a lung, and also any other diagnostic or screening procedures you would recommend for picking up the early cases, sir?
Raghu, I'm really pleased that the state government is looking at a screening tool.
Yes.
And if you look at the pickup rate for low-dose CT, the radiation dose is just a little more than a proper chest X-ray. And as Bashi very elegantly said, things have moved on. And now, a CT scan is available very, extensively in our state. So I think a low-dose CT would be a good screening tool, and it'll also be a way of collecting data. If we look at the criteria for screening these people. If you have somebody, as the Vice Chancellor alluded to, with a genetic predisposition, a family history of lung cancer, where they are non-smokers, they are young, and they have a fairly aggressive anaplastic variety of cancers in the family, then that would be a group that should undergo a screening. Smokers above the age of 65, in our country, I would say smokers above the age of 50. People who have a history of 20 pack years of smoking. Just like in cardiac surgery, it's very similar. It's the same disease process. It manifests itself differently inside the vessel walls and on the lung parenchyma. So smokers at the age of 50, people who chew pan, yes, you get oral cancers, but the oral cancers are squamous, and you can get upper lobe cancers in the lung as well. People who have a genetic predisposition, family histories, these are people who need to be screened with a low-dose CT. Now, if you say PET scan and other fancy things, that's really for ascertaining diagnosis. Now, PETs can be metabolically active in tuberculosis. So you'll have a problem with deciding what you're going to do next. So I wouldn't go for PET scans because they're expensive. They are not really a screening tool. They're really more of a diagnostic tool. So in my humble opinion, the best form of screening would be with a low-dose CT.
Sir, people with genetic predisposition, from which age they should be screened and how often they should be screened?
See, the people with genetic predisposition are a small number. The smokers are the highest. Now, with the genetic predisposition, the age group which we start looking at is for the age of 30. Because the children with malignant potential are looked at by the pediatricians, and adolescents, 20s, early 20s, very, very small proportion, and I'm not so sure that we will actually get the yield that we want in our population. So I would say 30 to 40 and stop. I think probably 2 scans, on an annual basis. And if you don't have any, abnormalities, I would stop.
Sir, one more question, sir. Still, do you think
Yes.
primary or secondary is more, common in your country, sir? You are shown some surgical interventions. You are handling more of primaries or secondaries?
Both, Raghu. See, with the primary lung cancers, we tend to do segmental resections on people who have poor respiratory reserve. These are people above the age of 80 with associated chronic obstructive pulmonary disease. We perform metastases, as I was telling Bashi, with very limited resections, like wedge resections with a centimeter away from the nodules itself. And the metastatic work for thoracic surgeons is not as high as for primary lung cancers. Primary lung cancers are the bread and butter of the thoracic surgeon in the UK, along with the surgery for COPD.
Thank you. Thank you very much, sir. It's a pleasure to have an interaction with you. Thank you.
No worries, Raghu. Anytime you need any help, just give us a shout.
Sure. Yeah, please. Thank you, madam.
Madam Sudha. Madam Sudha.
Yes, sir.
Can I ask one more question to Rajesh?
Yes, sir, you can ask, you can. I only, Anna, Professor Rajesh, I don't think this is your viva. Is this your viva?
It looks like it.
Uh,
I'm enjoying it though.
Please go ahead, sir.
I have one query I want to hear from you, that in our country, with such a huge population and diverse type of patient from this end to that end, what should be our protocol of lung cancer screening, particularly for those patients who don't have risk factors like smoking and familial cancer?
Baba, was very difficult decision to take, really, because you see, we've got to use our resource carefully, no?
Yes.
And the pickup of lung cancer, if you look at what happened in New York, they did the LCAP, which is the early lung cancer trial. And they looked at an area just outside New Jersey where they had a very large industrial area. So, if you like, dust was one of their issues. And they felt that this industrial dust could give rise to changes in the lung parenchyma and subsequently go on to cancerous processes. But if you look very carefully, critically at that trial, the pickup, they had very strict eligibility criteria. They said anybody who worked in the industrial dust disease, who had a cough, who had chronic cough, anybody who was smokers, anybody who were, had family history in that particular area, with others in their family having cancers, etc., etc. The pickup rate was 5%, right? And they also had pickup rates with low dose CTs of nodules. So they went to town taking out all of those nodules. And from those nodules, the cancerous changes were only 30%. So a lot of patients actually, to a certain diagnosis, underwent, in my opinion, my humble opinion, unnecessary resections. You see, so to extrapolate that sort of trial into our, low resource environment, I'm not saying that, we can throw resource at this, but are we going to look at something which gives you a yield of 5 to 10% in asymptomatic patients? I agree that if somebody has cough, if somebody has persistent cough for greater than 2 to 3 weeks, person brings up some blood, in that context, early intervention is necessary. Even in the UK, we have so many viral problems during autumn and winter, and people do bring up blood. But the protocol even here is for the GP to treat first with doxycycline for a week, and if it still persists, to get a chest X-ray. And if the chest X-ray shows the lesion or is consolidation, then go on to a secondary care provider. So, Baba, to have a national trial would be very resource laden and very cumbersome, in my opinion.
Well taken, sir. Well taken. I think you've made your point there. And Professor Vishwas, your remarks on that? Dr. Raghu, would you want to say something?
Yes, madam. Actually, the cancer registry, I think university we can look at it, madam, because of late, we, as doctor also was mentioning, we don't have a database in our country. So now at present, we are going for screening program and other things. So all this data, whatever we are collecting from the field level, we should be able to have a registry maybe at the university level, so that we also have a strong database in future, madam. That's why I want to make a remark.
Yes, sir. Yes, sir. Thank you for that suggestion. We shall look into it and work on that. We also have Dr. Shanti Malar, Dean of the Kilpauk Medical College with us, a renowned anesthesiologist. Madam, would you want to say something, madam?
Good afternoon and good afternoon to everyone. I just
Yes, ma'am.
joined little late, so I couldn't follow. But the problem is, as you said, the screening tool, they were selling about the X-rays and CTs, low-dose CTs. And already our NHM has have a protocol and they have opened a registry. Like we have to note down the X-ray findings of tuberculosis for the NTBEP, that is National Tuberculosis Elimination Program. So along with that, as Dr. Rajesh said, we can include that any nodal species of CA can be included as a registry also. Most of the patients here in our setup, as you know, as soon as they come, they want all the investigations to be done, including inside the government hospital itself. It's not like that doxycycline will be given, then 1 week after that X-ray will be taken. Here it is not possible at all. We have to do everything as early as possible. Otherwise, it will make a lot of complaints. So we have already the program regarding National Tuberculosis Elimination Program, and the X-rays and CTs are recorded, and this database is again started collecting. The NHM is doing the works, madam. And they are collecting all the reports from all the medical college hospitals and district headquarters hospitals. So like that, we can create a lung cancer, as Dr. Raghunandan said, cancer registry can be initiated. Thank you, ma'am.
Thank you, ma'am. Thank you for that. And a very lucid remark on what the ground reality is. Thank you, ma'am. And Dr. Soumya Sampath, the Dean of ESI Medical College, Chennai. Ma'am, any remarks, ma'am?
I just would like to congratulate Professor Rajesh on one of the best answer, and your thoracoscopy was a pleasure to watch. So I think for me, the takeaway from this is that I'll have to initiate a proper meticulous documentation in my institution, and then we can talk about a national database and a registry. So that would be the way forward for us, I guess. So thank you, VC ma'am, and thank you for a wonderful presentation, Professor Rajesh.
Thank you very much.
Thank you, ma'am. Thank you. Thank you.
Sudha, if I can just
Yes, Anna, please go ahead. Please.
add something. You see, if I think the starting point at home would be multidisciplinary team meetings. I'm sure Raghu runs some of these in MMC, but if we can get, see, when I was a student, Professor Rangabasham used to have interesting cases discussion in the afternoons in the radiology department. He used to bring some bariums and he used to bring some stuff and X-rays and things, and they used to have discussions. So we do have a past history of people sitting together and talking about it. Now, when I was in MMM for a year, when Bashi joined soon after I finished and left to the UK, we used to have Saturday seminars on all of the pediatric cases, all of the adult cases, and KMC used to chair that meeting with TJC as well there. And there was a discussion, and that's a huge learning opportunity for all of the juniors. The nursing staff used to come and sit there and say, why are we operating on this patient? Or why are we not doing an angioplasty on this patient? You see? So I think if every institution spends just 3 hours in a week, getting together, bringing all of the X-rays together, the pathology together, as we did. Because when we did that, it became a discipline. And I'll tell you what I learned from the MDTs. some oncologist will go to the American Society of Clinical Oncology meeting, ASCO meeting in Los Angeles or San Diego or somewhere. They'll come back and say, you know what? This is the new thing. You don't have to go and read up journals and stuff. There's somebody who comes and tells you that. Similarly, when I go off to the European Association or the American Association of Thoracic Surgery and come back, it was my obligation to inform the MDT after I come back as to what were the recent advances, what can we use. So if you like, it's a two-way dialogue system where the hospital allows you to go away for 3 or 4 days to wherever and they pay for it, but they don't expect you to have gone off with some girlfriend to do some skiing or some such thing, but you have actually sat there in the meeting and learned something and come back and disseminate it. So, you know, we all learn at the same time. The pathologist will say, no, that is not adenocarcinoma, that's non-mucinous adenocarcinomatosis and some such thing like that. And you think, what the hell is this? You know? So you learn at the same time, but you share the knowledge. The patient gets the best deal. And I'm sure every one of us can spend 3 hours in a week sitting together with some coffee, samosa, you know, jalebi and all that, and, you know, discuss.
Yes, sir. Point very well taken. We'll try and initiate some kind of jalebi meets. Yes, we'll try and have some discussions across the table. But that's a wonderful idea because learning goes on there. It's a kind of learning, and you know, we have the old adage which says "Kattralin kettale nandru." You know, you don't have to sit and learn everything by yourself. You climb on the
Absolutely.
shoulders of others who have learned and then see the world, which
Absolutely.
appears larger and brighter. Yes, your point.
See, now,
Yes, sir.
if you ask Bashi, he'll tell you about aortic surgery. He will give you a discourse on aortic surgery. He will tell you how he did his first aortic operation in Australia, which I heard when he gave that wonderful lecture in the IAC, in the Asian meeting in Chennai. So, you know,
Okay.
we all learn from each other. If we sit together just for 3 hours, you know, operate, fine. But what does the pathologist do? What does the radiologist do? How can he put some wire somewhere and do something for us? You know? So I think that's the way that I learn, really.
I think
Yes.
Sudha can take some lead to keep us together, have some meet maybe a little more frequently, where we can learn small things from other
Yes,
people.
sir. I think I would be able to do that with all your wishes and support and guidance. Elders like you who could guide, then I think it would work out. I also have people like Dr. Shantimala, Dr. Soumya, Dr. Raghu, all of them giving their support. And as Dr. Soumya said, we'll try and take all these ideas forward at every level, at every stratum. We'll try and take these ideas forward. Thank you very much, Professor Rajesh, for a wonderful session. No words.
I have got one more request to that at the end.
Yes, sir.
Can I request Rajesh to share this presentation? Being so simple and informative, we would like to see repeatedly. Can you share this slide to all of us through this presentation?
I have no problem. You know, Sudha can send it to anybody she wants.
Yes,
Okay.
sir, this is already there in our YouTube. Tamil Nadu Dr. M.G.R. Medical University has a YouTube line, and all these webinars are immediately hosted onto the YouTube. There are people who are watching it live now on the YouTube. Few of us are in the link of the webinar, but then many of them, hundreds of them are watching in the YouTube. It's there in the YouTube. And I would also arrange to send you the slides. I would send it to Vishwas mail. That would be okay, sir?
Yes, sir, absolutely fine.
Yes, I should do that, sir. And thank you very much once again, Professor Rajesh, for a very wonderful session. And I must thank Professor Bashi and Professor Bishwas for their excellent scholastic remarks and a wonderful interaction today. We'll meet again in the next edition of this webinar series on the 22nd of October. The third, it would actually be the fourth Friday of October, but then 15 days from now, the 22nd of October, 2:30 p.m. IST, Dr. Mohan Kameshwaran, one of the distinguished professors of this university and a distinguished ENT surgeon, would be talking to us on an extremely unique topic. Professor Rajesh was mentioning about how patients get scared when they would have to have a large thoracic scar. And then he was also talking about simpler investigative techniques when we go to the rural area. All that reminded me of medicine being practiced as an art. And Dr. Mohan Kameshwaran would be talking to us on the very same topic, modern medicine, the conflict between the art and the science. That would be the topic on which he would talk on the 22nd of October. I take this opportunity to invite each one of you for the next edition of the webinar series. I hope we would have another round of excellent discussions on the 22nd. Welcome to our next edition, and thank you very much for this day. Thank you.
Thank you, ma'am.
Thank you. Thank you very much.
Thank you very much, madam.
Thank you. Thank you, Bashi.